This is Miss Yeomans doing a lecture number 2 for OBGYN Clinical 2. So we're going to start with the collection of the specimen. One thing we have to remember is there are several different instruments that our physician may choose to use while doing the collection of their specimen. So what we're doing is we're gaining a sample of the squamous epithelial cells. And remember, those are those thin little flat cells that are on the outside of the cervix. So they're going to also use scraping of cells from that ectocervix and the endocervix. So it can be taken from the vagina, but it's not usually done unless the vaginal lesion is observed. And what we would do would be to use that maturation index. Okay, so when we're doing the pelvic exam, if a vaginal specimen is needing to be collected, it would actually be collected first. And we would use the rounded end of the spatula. Typically that would be collected from the vaginal pool in the posterior portion of the vagina. And then also you could even do a specimen from a lesion. So that if the doctor observes a lesion in there, they might want to do a slight scraping of that so they can get some of those tissue samples to send off. And the maturation index is collected from the upper third of the lateral vaginal wall. Okay. The cervical specimen is an S-shaped end part of this spatula that you will actually use for collecting the specimen, but it's placed just inside the cervical canal, and what the doctor does is go into a 360-degree turn to obtain the ectocervical cells, and what we're going to do is send those off for evaluation as well. Now, we also have the endocervical specimen, which is obtained with that endocervical brush, and this is what we call the Broom. So it is actually used because those bristles are soft, and it can be inserted into the canal, and that doesn't have any pain or discomfort for the patient, nor does it damage the tissue. So the brush is inserted into the canal instead of the spatula. So the endocervix, we're gathering the mucous membrane lining of the the endocervical canal, and there's different ways to send those cells to the lab. So one of the first ways is to do a thin spread of each specimen onto a glass slide. And the thing you have to remember with any time you obtain a specimen from whatever source, you have to label it. So the abbreviations that we use for labeling any of those cervical or endocervical types of specimens is going to be vaginal, cervical, or endocervical, so V, C, and E. Okay, so that slide has to have that information on it in order to be able to distinguish where those cells came from. So maybe it's coming from different areas. Well, we need to know if one of those areas comes back positive for abnormal cells. We need to know where it came from. Okay. So then we have that direct smear, which actually puts the smear right onto that slide, and we use a 95% ethyl alcohol or Cytology fixative spray to make sure that it adheres to the slide. And typically we will use Aquanet hairspray. So that's why the Aquanet's in the rooms at the OBGYN office. And what that does, it allows that bit of cells to stay there on the slide. But you do have to let that dry thoroughly before you pack it all the way up. Okay. Then you have your liquid-based preps, which is what most of our physicians have gone to at this point. There's different brand names. You've got a Thin Prep, Pap Test, an Autocyte, and a SurePath. And around here it's SurePath. So why do we choose liquid-based over the slide method? Well, you get a better specimen. because you're actually getting all of the cells. You're reducing the false negatives. You're actually getting as many true cells as possible. You still have to label the container with where those specimens came from. So again, the physician's going to use a different type of instrument to obtain those different cells. Okay, the plastic broom is the most common type of instrument used, but it also is used to collect the liquid-based prep, because when you actually obtain those cells and you stick the broom into the container, you're going to, what the textbook says is to rotate the broom 10 times into the fixative liquid solution, and that helps to loosen up the cells. I like to tell you to be a little bit more aggressive, kind of like you're scrambling eggs before you put them in the frying pan. So you scramble those eggs up, and you're actively and vigorously trying to get those cells off of the brush to stay into the liquid base. Now sometimes you might even have a broom that you can detach the end of the broom, or even break off the end of the broom to stay in the solution, and that's like the best way to make sure that you're getting all the cells to the lab. So again, this is going to reduce those false negatives, and you're getting the truest result for your patient. Alright, so what happens after the laboratory receives the specimen? Well, what they're going to do is they're going to try to separate the cells from the debris, and they're going to try to decide, okay, these are the good cells, these are just nasty debris, as we would say, a contaminant, if you will. So we're trying to find the good cells and base our observation and results on just that. Okay, so again, this just tells you why the liquid-based prep is best. All right. Okay, so the cytology request. This is really a big thing that we have to remember to do when we're sending in that specimen. Every little section needs to have something placed in there with the patient's information, where the specimen came from, the doctor's office information, where to send the results to. All of that information has to be in there. So this is just going to walk you through some of that information. The date and time that the specimen was collected is very, very important. It also is important to have that LMP on there, so that way the doctors, the pathologist, will understand that if there's some blood cells detected, if they have just finished their menses, or if they're about to start their menses. Okay. All right. So again, this is going through some of those instruments that are used, the cytology request. We also need to put in the medical history for the patient on that cytology request, if they're pregnant, lactating, if they're using oral contraceptives, if they're postmenopausal, if they're on HRTs, and if they have postmenopausal bleeding, because that also gives the pathologist an idea of what's going on with that patient when they're observing those cells under the microscope. If they're postpartum, if they use an IUD, if they're having postcoital bleeding, which is very important, if there's DES exposure, and then of course if they've had a previous abnormal pap smear. Okay, so all of that is extremely important that we list on that cytology request. And we also need to notate if they've had any cryosurgery or colposcopies or biopsies. Some of the other types of procedures that they could have had that need to be noted on that request: if they've had a LEEP, if they've had a hysterectomy, if they've gone through chemo or radiation, any of this other stuff that's listed here. Then of course in your textbook and here on the screen you can see there is a cytology request. It's very simple, very self-explanatory. You just have to take every box for what you're trying to do. Okay, So let's keep looking and see here. If there is an abnormal cell that's detected, then what's going to happen is the cytopathologist is going to look at that and confirm it prior to the results going out to the physician. So there's a lot of confirmation with any abnormal readings. There might even be some further testing that goes on. Alright, so what is the Maturation Index? It's an endocrine evaluation, and that's performed on the cells that are taken from the lateral vaginal wall. The purpose is to assist in evaluating the cause of infertility, menopause or postmenopausal bleeding, and amenorrhea. And it really is looking at mostly those hormones. So we make sure we want to indicate that if we want that tested. Now, the Bethesda System is used to report Pap test. It was developed by the National Cancer Institute in Bethesda, Maryland, and it provides a detailed description rather than just a class. You know, those of you that might be a little bit more seasoned, like I am, you probably remember the class 1 through class 5 Pap results. So now the system that's used is the Bethesda system, so we get more specifics. And it's very good because you never want to give vague results. It's always nice to give very, very direct results. Okay? Alright, so looking at the bimanual exam, this is actually done by the physician after the Pap smear is collected and the speculum is removed, and the physician inserts the index and middle fingers of their lubricated glove. So that's when we're going to put that lubrication on their hand, or maybe we give it to them on a 4x4 and they touch the lubrication. But they're going to put the lubricated hand into the vagina and use the unlubricated hand on top of the lower abdomen of the patient, and they're going to feel the areas that the organs are placed in. So they're looking for size, shape, position, and if there's any specific tenderness or lumpiness that they detect. The rectal vaginal exam is actually checking to see if there's a tear in that tissue between the rectum and the vaginal area. So that is a very easy and delicate piece of tissue that can become torn, but we're also doing this to see if there's any lumps in the end of the rectum and checking for occult blood. A lot of times physicians will detect hemorrhoids that are internal with this, also a fistula or a fissure. Again, that was the tear in that tissue. Alright, so we do that fecal occult blood test, and typically that's done on patients beginning at age 40. So we want to make sure that if there is any blood that's found in the stool, that we report that so that the physician can decide, is this due to hemorrhoids, or is this something that we need to look at further by sending that patient on to the GI doctors for some further testing like a colonoscopy, that type of thing. Okay, so vaginal infections. We know that this is something that's very easily occurring with our patients because it's a warm, dark, moist environment, just like the mouth. So it's very easy for this to be a breeding ground for microorganisms. So we typically see a lot of vaginitis with patients if they're not doing a good job with hygiene. Sometimes that could be even because they're just having frequent intercourse, or maybe they are just a good carrier of different types of bacteria. So if there's an unusual discharge that we notice or the patient notes to us, the physician typically will do a little specimen collection so we can identify what that is. So what we would be responsible for doing would be to gather all the equipment that's needed, get a lab request form and the containers so that the physician can gather that specimen. Then of course we would assist with the collection and then send off that specimen to the laboratory. Alright, so one of the most common types of STDs that we see in this area is Trichomonas, and the term for that is Trichomonas vaginalis. The causative agent of Trichomonas, or trick, is a pear-shaped protozoan with flagella. Remember, that's the little arms that move, and that allows for the organism to move around through the vagina and get to all the healthy tissue and cells. It's usually, but not always, spread through intercourse. The symptoms are important. You have to remember this has a profuse, frothy vaginal discharge, and that discharge is normally a yellowish green color, and it has an unpleasant odor. Some of the symptoms for trichomonas is itchy and irritation of the vulva and vagina, dyspareunia and dysuria, and the cervix may exhibit some small red spots, and the physician may make mention of a strawberry cervix. So that tissue in the cervix actually looks like the skin of a strawberry. Okay. With the infection, we do a wet prep in the office, and we take some of that discharge with a swab that's sterile. We use the isotonic solution, and we use the cover slip that's placed over the slide to protect it while we send that off to the lab. So the wet prep in the office, the physician examines under that microscopic area for the trichomonas to see if there's any motility of that organism. So is it moving around a good bit, or is it dead cells? And then, of course, sometimes we send that out to the laboratories, and we should have a result within 24 hours. Candida albicans, most likely termed a yeast infection. It's not truly an infection, it's just a yeast. It's normally found in the intestinal tract. It's frequent in the vagina because it is a warm, dark, moist environment, but it does not cause an infection. Typically, we will see this with our pregnant females, definitely with our diabetics, and then with our patients that have prolonged antibiotic therapy. If you work in a general practice office or internal medicine, urgent care, you're prescribing a lot of antibiotics for different types of infections like sinus infections, bronchitis, pneumonia, so on and so forth. You need to remember with your female patients that you should ask them, do you get a yeast infection when you take antibiotics? And if so, you need to definitely get them some medicine for that. Okay? So, symptoms. The white patches on the mucosa of the vagina is a thick, odorless, cottage cheese-like discharge, and it causes a lot of burning and itching to the vulva, and it also causes dysuria. Alright, so how do we identify it? With the wet prep, typically you take that discharge and you drop a little drop of the 10% solution of the KOH added to a slide, and it allows that debris to get out of the way, so you can see that Candida a whole lot easier. So with the wet prep, the physician observes the slide under a microscope for the Candida to see how it looks. Okay? Oftentimes it's sent off to the laboratory for a final conclusion. Then, of course, you have good old chlamydia. This is one of the most frequent and rapidly growing types of STDs or STIs in the United States. And particularly we're seeing these within young adolescent females because they're more sexually active and promiscuous, if you will. Well, the big thing with chlamydia is most of your patients are asymptomatic, so they don't even know they have it by the time they seek medical attention. Sometimes there have been a lot of problems to occur to their reproductive tract that will last long term. First, it attacks the cervix, which causes the cervicitis, so typically they will have dysuria, itching, irritation to the genital area. They might even have a yellowish, colorless vaginal discharge that appears about 1 to 3 weeks after infection. Yes, not 1 to 3 days, but 1 to 3 weeks. So it's a long time before they become symptomatic. If it's left untreated, it can lead to PID. So those symptoms, they're listed here. So you've got the lower abdominal pain, fever, nausea, vomiting, dyspareunia, vaginal discharge, and then even some bleeding in between periods. So if we leave that treated. The PID can actually cause chronic pelvic pain, scarring of the fallopian tubes, ectopic pregnancy, and even infertility, which is one of the big things. Okay, Chlamydia in men. The men are more likely to have symptoms like the dysuria and then that thin watery discharge from the penis. They appear earlier in the day, so that might be even just kind of overlooked by the male. It's like, oh, well, I just, had some discharge during sleep. But if it's left untreated, it can cause epididymitis and also infertility. So how do we diagnose it? Typically, we would do the DNA testing. We can do that with a sterile swab, both with females and males. We take that swab from the urethra. We want to tell the patients not to void for an hour before they have this test done. Okay, so we send that off to the lab so it can be identified for sure. Okay. Then the last one that we're going to talk about with STIs is gonorrhea. Gonorrhea and chlamydia are the most common ones that we're seeing in this area. It is a gram-negative diplococcus. It's an infection of the genitourinary tract. It is an STD, so it is transmitted through sexual intercourse. It's most commonly associated with good old chlamydia. Okay, women are asymptomatic typically, but if they do have symptoms, it'll be dysuria, that yellow vaginal discharge that typically starts about 2 to 10 days after they become infected. They could be mild symptoms, so that could even be ignored. Obviously, if it's left untreated, it can cause pelvic inflammatory disease that can lead to infertility. So that is always one of those problems with STDs. We've got to get those patients treated or they can become infertile. With men having gonorrhea, they actually exhibit those symptoms more frequently than women. They're going to have the dysuria, the whitish discharge from the penis. It may be thick and creamy in consistency. So they are more likely to have that burning or dysuria. And of course that can lead to infertility of the man as well. So we do a DNA probe where we take that specimen and send it off to the lab. Going to end right here and then pick up with obstetrics.